Welcome back to the deep dive. Today, we are tackling a subject that, well, everyone has one, but almost no one really understands it until it betrays them.
Yeah, that's a good way to put it.
We're talking about the colon. And before you tune out thinking this is just some biology refresher, let me just stop you right there.
Yeah, this is not your high school textbook.
No, we are walking into the operating room. We're looking at this through the eyes of a surgeon.
We are, and we're bringing the heavy artillery with us.
We are using the Sebenstein standard. For anyone who doesn't know, this is the book. This is the one that sits on the desk of the surgeon who is about to open you up.
It is the Bible, yeah.
It is the Bible of high-stakes, consultant-level surgery. And when you look at the colon through this lens, it's not just plumbing.
Not at all. It's a battlefield, a strategic map.
That's the phrase that jumped out at me in the research. We think of it as this passive pipe, stuff goes in, stuff comes out. But Sebenstein paints it as a vascular and lymphatic unit. It's a highly complex strategic map where a difference of millimeters, literally millimeters, determines whether a cancer patient is cured or if they face a catastrophic recurrence.
And that's the mission today. We're going to decode that map. We are going to answer the why. Why do surgeons cut where they cut?
Right.
Why does a tumor on the right side of your body act completely differently than one on the left? Why does the liver get involved so quickly? And it turns out the answers aren't random.
No.
They were written into your code before you were even born.
The why is what we're here for. So let's start at the very, very beginning. I mean, the absolute beginning.
The blueprint.
The blueprint. Because reading through this, I realized you can't actually understand the adult colon unless you understand how it was built in the womb.
That is the foundational rule of visceral surgery. The anatomy you see on the table, that's just the end result of a very dramatic embryological process.
So let's talk about the Great Divide, because when you look at a diagram of the colon, it looks like one big horseshoe.
Yep. One continuous organ.
But you're saying that's an illusion?
It is a total illusion.
Yeah.
Embryologically, the colon is actually two completely different organs that just happen to fuse together in the middle.
Really?
Yeah, it's like two different rail lines meeting at a central station.
Yeah.
You have the midgut and you have the hindgut.
Okay, let's trace the border. Where is that line in the sand?
It's invisible to the naked eye, but it sits roughly 2/3 of the way across the transverse colon.
So the part that runs across the top of your abdomen.
Exactly. Everything before that line, the cecum, the ascending colon, and that first, big chunk of the transverse, that's all midgut.
And after?
Everything after the descending colon, the sigmoid, the upper rectum, that's hindgut. Two different origins.
So somewhere along that transverse colon, the whole origin story just changes. But here's the big question. So what?
Right.
Why does a surgeon holding a scalpel over a 60-year-old patient care about what happened to the embryo?
This is the first consultant pearl from our source material. Colon cancer surgery follows embryologic planes, not arbitrary lengths of bowel.
What does that mean, embryologic planes?
It means the origin predicts everything else. It predicts the vascular pedicles, the blood supply. It predicts the lymphatic drainage paths. It predicts the nerve supply. It's all connected.
So you can't just look at a tumor and say, okay, I'll cut 2 inches to the left and 2 inches to the right and call it a day.
Absolutely not. If you do that, you are playing Russian roulette with the patient's life.
Wow.
Cancer doesn't respect rulers. It respects flow. Cancer cells travel along the supply lines, the blood vessels and lymphatics that were established when you were an embryo. If you just cut 2 inches out, you might be leaving behind the specific lymph nodes that drain that exact segment.
So you have to remove the entire embryologic package.
Exactly. That's the perfect term for it. If the tumor's in the midgut, you have to take the entire midgut vasculature. If it's in the hindgut, you take the hindgut's territory.
You're operating on history.
You are. You're respecting those ancient borders.
That is fascinating. It really is like map reading. You have to respect the original borders. Now, there's another part of this blueprint phase that just sounds incredibly dramatic. The rotation.
Oh, the rotation is wild. It's honestly a miracle it works as often as it does.
Okay, walk us through this gymnastics routine.
So early in development, the intestine grows way faster than the abdominal cavity. There literally isn't room for it inside the baby.
Okay.
So the midgut herniates out, it goes out through the umbilical cord, and it hangs out outside the body for a while.
Wait. So part of our development involves our intestines being outside of us?
Yes. For a time, yes. And while it's out there, it starts to twist.
Yeah.
Then as the body grows and creates space, it pulls the intestine back in. But it doesn't just stuff it back in randomly.
It can't.
No. It comes back in while performing a 270-degree counterclockwise rotation.
270 degrees, that is a serious spin.
It is. And that rotation is what places the organs in their final positions. It swings the cecum down to the right lower quadrant. It swings the transverse colon across the top. It's like origami with human tissue.
But what's the surgical consequence? You mentioned that.
The surgical consequence is that this rotation determines fixation.
Fixation. Okay, so that implies some things get stuck down and some things don't.
Correct. As the colon rotates and lands against the back wall of the abdomen, certain parts of it fuse to that wall. We call that secondarily retroperitoneal. They are, for all intents and purposes, plastered down.
Okay, so which parts get the glue?
The ascending colon on the right and the descending colon on the left. They get pressed against the back wall and they fuse there. They are fixed. They don't move.
And the parts that float?
The transverse colon and the sigmoid colon, they stay intraperitoneal. They have what's called a mesentery, which is like a long, fatty leash that gives them mobility.
And again, applying this to the battlefield concept, why does this matter when things go wrong? Let's say there's a perforation, a hole in the bowel.
This dictates the disaster. Think about it. If the ascending colon perforates, remember, it's retroperitoneal. It's stuck to the back.
Right.
The leak might be contained. It leaks into the retroperitoneum, this space behind the main abdominal cavity. The patient might not look that sick initially. Their belly might feel soft because the infection is all hidden behind the wall.
It's a stealth leak.
It's a total stealth leak. But if the transverse colon perforates, that part is floating free in the abdominal cavity.
So it's an immediate spill.
That infection spills into the main chamber immediately. You get generalized peritonitis. The belly becomes rigid, board-like. The patient gets incredibly sick, incredibly fast.
So the anatomy dictates the presentation. The rotation determines whether a leak is a hidden abscess or a full-blown 5-alarm emergency.
Precisely. It also explains mobilization planes. When a surgeon needs to remove a piece of the colon, say the ascending colon, they have to peel it off the back wall.
They're reversing the process.
They are essentially reversing that embryologic fusion. They're ungluing it.
How do they know where to cut?
They look for the white line of Tolt. That is the visible scar of that original fusion. If you cut along that white line, the colon peels off the kidney and the muscles like a sticker off a backing sheet.
Wow.
You are re-separating what the embryo glued together billions of years of evolution ago.
That is such a cool way to visualize surgery. You're finding the seam in the wallpaper. But speaking of things going wrong, sometimes the blueprint glitches.
Oh, yeah.
The source material spent some time on embryologic anomalies.
Yes. When you have a process as complex as a 270-degree rotation and reentry, sometimes it stops early or it over-rotates. This leads to malrotation.
Which sounds like a bad day for a mechanic, but probably worse for a human.
Much, much worse. In malrotation, the right colon doesn't get fixed to the back wall. It stays mobile. Imagine the intestine is supposed to be taped down, but instead it's just hanging there on a narrow stalk.
That sounds unstable.
It creates a super high risk for volvulus.
Volvulus. That's a word that sounds exactly like what it is.
It's a twisting. Think of a garden hose. If you pull it straight, water flows. But if you twist it, it kinks. Because the bowel isn't anchored, it can twist around its own blood supply.
And cuts off circulation.
It cuts off the circulation. It's a catastrophic emergency.
Yeah.
The bowel turns black and dies within hours.
And what about mobile cecum syndrome? Is that similar?
Similar concept, just more localized. The cecum, the very start of the colon fails to stick down, so it just flaps around.
Like a loose shutter in a storm.
Good analogy. And it can twist on itself, causing a cecal volvulus.
The source also mentioned something called congenital bands.
Ladd's bands. These are leftover bits of tissue, little fibrous bands from that chaotic developmental phase.
And they can cause problems.
They can act like little lassos inside the abdomen. A person might go 40, 50 years with no issues. And then suddenly a loop of bowel gets caught under one of these bands and they have a complete obstruction. Surgeons often only find these when they go in to fix the blockage.
Now, there was one anomaly that really stood out to me because it sounded mechanical, but also neurological. Hirschsprung disease.
Ah, yes. Hirschsprung's is a fascinating and tragic condition, usually found in infants. It focuses on the hindgut.
The source called it a ganglionosis.
Right, a gangliosis. No ganglions. Basically, during development, the nerve cells, the software that runs the gut, they migrate down the intestine like a wave.
From mouth to anus.
Exactly. In Hirschsprung's, that wave of nerve cells it stops short, usually somewhere in the rectum or the sigmoid colon.
So the nerves just gave up before they reached the finish line?
That's a perfect way to put it. So that final segment of the colon has no nerves to tell it to relax.
So it's permanently clenched?
Permanently spastic. It's what we call a functional obstruction. The plumbing, the tube itself, is physically open. There's no wall blocking it.
But the pump is broken.
The pump is broken. That segment stays contracted, and nothing can pass through it. The result is severe constipation from birth. The baby literally cannot pass meconium, the first stool.
And the insight there, which I found really interesting, is that hindgut anomalies usually present as functional issues, whereas midgut anomalies are often these structural twists.
That's a great synthesis.
Yeah.
Yeah. Midgut anomalies tend to be mechanical disasters like twists and kinks because of the lack of fixation. Hindgut anomalies, like Hirschsprungs, are often failures of the operating software, the nerves.
Okay, so we've built the house, or at least we know how it was built. Now let's turn the lights on and look at the landscape. If a surgeon opens the abdomen, it's crowded in there. You've got small intestine, large intestine, omentum. How do they know instantly? That right there, that is the colon.
It's not as obvious as it looks in a textbook drawing where everything is neatly color-coded. In real life, everything is pink and slippery and, kind of looks the same.
Right.
But there are 3 visual identifiers. I call it the trinity of the colon.
Okay, walk us through them.
First and most importantly, the tenei coli.
The racing stripes?
Essentially, yes. The longitudinal muscle of the colon isn't a continuous sheet like it is in the small intestine. It's bundled into 3 distinct strips running the length of the colon. These are the tenei.
And why are they so important?
For a surgeon, specifically a general surgeon dealing with appendicitis, the tenei are the North Star.
Because they lead somewhere.
They converge at the base of the appendix. All 3 of them come together right where the appendix starts. So if you're digging around in a messy abdomen, maybe there's inflammation, maybe there's pus, and you can't find the appendix, you find a tenea. You follow it down like following a road, and it will lead you right to the prize.
That is a handy tip. Okay, what's number 2?
Haustra. These are the sacculations, the pouches that give the colon that segmented, bumpy look. The small intestine is smooth, the colon is haustrated. It looks kind of like a string of bubbles.
And number 3?
Appendices epiploicae.
Okay.
These are little fatty tags or pouches that hang off the colon. The small intestine doesn't have them. They're like little flags just waving, saying, hey, I am the large intestine.
Okay, so we have the visual ID, but we also need to talk about the terrain. We touched on this with the rotation, the fixed zones versus the mobile zones. But the source mentions this is critical for avoiding danger zones, specifically regarding the ureters.
This is huge. This is where lawsuits happen.
Mm-hmm.
The ureters, the tubes carrying urine from the kidneys to the bladder, run along the back wall of the abdomen. Remember, the ascending and descending colon are plastered to that same back wall.
I see the problem. They are neighbors sharing a wall.
Exactly. And they are very close neighbors. So
Yeah.
when you are mobilizing the left colon, peeling it off the back wall to remove a cancer, the left ureter is right there, often hidden in the fat.
That's vulnerable.
Very. If you aren't in the correct embryologic plane, that holy plane we talked about, you can accidentally cut or clamp or burn the ureter.
Which is a very bad day for everyone.
A very bad day. That's why understanding the peritoneal relations is safety step number 1. You have to know what lies beneath the floorboards. You need to be able to see through the tissue with your mind.
Before we move to the blood supply, let's just zoom in for a second. Microscopic view. What is happening at the cellular level that makes the colon different?
The biggest difference is what's missing. The colon has no villi.
Okay.
The small intestine is covered in these things called villi. They're tiny fingers that absorb nutrients. The colon doesn't really need those. Its main job isn't nutrient absorption.
It's water absorption.
Right. So instead, it is packed with goblet cells.
Mucus factories.
Precisely. The colon's job is to move increasingly solid waste. It needs lubrication. So the mucosa is studded with these goblet cells, just pumping out mucus to keep things sliding along. It's an industrial lubricant system.
Okay, moving on to what I think is the most complex but arguably the most important part of this deep dive, the supply lines, the vascular and lymphatic networks. The source material calls this the oncology core.
It is. You cannot perform cancer surgery without mastering the arteries. And again, where do we go back to?
Oh, the great divide.
Midgut versus hindgut.
So let's map the highways. The midgut, the right side of the colon, gets its blood from where?
The SMA, the superior mesenteric artery. Think of this as the northern supply road. It's a huge vessel right off the aorta, and it sends out 3 main branches to the right colon. The lateral colic, the right colic, and the middle colic arteries.
And the hindgut, the left side?
The IMA, The inferior mesenteric artery. That's the southern supply route. It's a bit smaller, and it supplies the left colic and the sigmoid arteries.
So two totally different systems. But surely these two systems have to talk to each other. What if one gets blocked by, say, a clot or something?
They have to. They absolutely have to. If one system gets blocked, the gut needs a backup plan. That backup plan is the marginal artery of Drummond.
Okay, the marginal artery, it sounds like an orbital highway.
That's a great way to think of it. It's a collateral vessel that runs right along the rim, the margin, of the colon, connecting all these arteries. It connects the SMA system to the IMA system.
And this is critical for surgery.
The preservation of this artery is often the single deciding factor in whether in anastomosis a reconnection of the bowel survives or dies.
Because if you cut the main supply to remove a tumor, the marginal artery is the only thing keeping the remaining tissue alive.
Exactly. It distributes the blood from the remaining highways. And there's another sort of variant called the arc of Riolan, which is like an express lane that connects the SMA and IMA closer to the root.
A shortcut.
A shortcut. And it becomes absolutely critical if the main highways are blocked by atherosclerosis.
But highways have dead zones. The source material spends a lot of time warning about watershed areas.
These are the Achilles heels of the colon. A watershed area is the exact point where one blood supply system ends and the next one hasn't quite taken over yet.
It's the furthest point from the pump.
It's the end of the line, the very last stop on the bus route.
The text identifies the splenic flexure as the big one.
Right. That's that sharp turn on the upper left of your abdomen, up by your spleen. It's the meeting point between the mighty SMA and the IMA. The blood pressure is naturally lowest there.
So if a patient goes into shock, say, they have a heart attack or severe dehydration, and their blood pressure just tanks.
The splenic flexure is the first piece of tissue to die. It strokes out. We call it ischemic colitis. The tissue just doesn't get enough oxygen and it marks.
And surgically, this is a nightmare zone.
A total nightmare. If you try to sew two pieces of bowel together right at a watershed point, you are sewing tissue that is already starving for oxygen. It's not going to heal.
And the source is blunt about this. I wrote down the quote. Most leaks are vascular failures.
This is the quote to remember.
Yeah.
A surgeon can sew a technically perfect line of staples, beautiful work, but if they did it in a watershed zone without checking the blood flow, the tissue dies, the staples pull through like a zipper in rotten fabric, and you have a leak. A catastrophe.
Now, we've talked arteries. Let's talk veins. Where does all the blood go after it's delivered the oxygen?
The superior mesenteric vein, the SMV, and inferior mesenteric vein, the IMV, drain into the portal vein.
Which goes straight to the liver.
Correct. And this explains the metastasis pattern. Why does colon cancer go to the liver first? Why not the lungs? Why not the brain?
It's not random.
It's not random at all. The venous blood creates a direct superhighway carrying cancer cells straight from the colon into the liver, which acts as the first filter.
That makes perfect sense. It's not biology, it's plumbing. Now let's talk lymphatics. The source has a golden rule here.
The rule is simple and elegant. Lymphatic drainage follows the arteries.
Why is that the golden rule for cancer surgery?
Because cancer spreads through lymphatics. That's its escape route. It goes from the colon wall to the little nodes right on the bowel wall, the epicolic nodes, then to the nodes along the edge, the pericolic nodes. Then it climbs up to the intermediate nodes along the vessels, and finally to the main nodes at the root of the artery.
So it climbs the vascular tree.
It climbs the tree. So the entire surgical strategy is based on high ligation.
High ligation, meaning...
To cure cancer, you can't just pick the fruit, which is the tumor. It's to cut the branch at the trunk. You take the feeding artery right at its origin from the aorta.
Why go so high up?
By doing that, you ensure you are capturing the entire lymphovascular basin, every single lymph node that drained that tumor. If you cut too far out, closer to the bowel, you might leave a positive lymph node behind near the root.
And the cancer comes back.
And the cancer comes back. That's why we say margins are vascular, not just a measurement of distance.
Incredible. It really is a strategy game. You are defining the enemy's territory and removing it entirely.
That's the job.
I want to pivot now to the engine room, the physiology. Because this explains one of the most baffling mysteries in diagnosis, the tale of two cancers.
Yes.
The source describes how right-sided tumors and left-sided tumors feel like completely different diseases to the patient.
And it all comes down to physics and plumbing. First, you have to understand the colon's day job. It's not glamorous. It is a drying machine.
A drying machine.
A drying machine. Its main job is water and electrolyte absorption. It receives about 1 to 2 liters of liquid from the small intestine every single day. Its job is to reclaim that water.
How does it do that?
It actively pumps sodium out of the stool, and chloride and water just passively follow along.
So on the right side, the very start of the colon,
Hmm.
the stool is basically liquid. It flows like water.
Exactly. And the right colon, the cecum, has a huge diameter. It's wide. So imagine you have a tumor growing there. The stool is liquid, the pipe is wide. Does it get blocked?
Probably not. The liquid just flows around the lump.
Correct. So the patient doesn't feel constipation, they don't feel pain. Instead, that tumor just sits there growing and ulcerating. It bleeds. But it bleeds into liquid stool, so it all mixes in. The patient never sees bright red blood.
The silent anemia.
That's the classic presentation. They show up to their doctor complaining of being tired all the time, they look pale, their blood count is low, but their bowel habits are totally fine.
Now, contrast that with the left side.
By the time stool hits the left side, the drying machine has done its work. The stool is solid, it's formed, and the left colon, it's a narrow muscular tube, much narrower than the right side.
So you have a solid object trying to pass through a narrow tube that is now being pinched by a tumor.
Traffic jam, a complete blockage. The patient notices immediately, "Doc, I can't go to the bathroom. My stool is thin like a pencil." They get cramps, they get obstruction, they present with an emergency.
It's incredible. The anatomy and the physiology dictate the diagnosis. Right side, silent bleeding. Left side, loud obstruction. All because of water absorption and tube diameter.
It's physics and biology intersecting perfectly.
And what about movement? Motility. We know things move, but how?
Well, there are two main types of movement. You have segmental contractions, which are just mixing movements, churning the contents to expose them to lining for that final bit of water absorption.
Like a washing machine agitating.
Yeah, that's a good way to put it. And then you have the mass movement,
The big push.
the big push. These happen a few times a day, usually after eating. It's a powerful, coordinated wave that propels stool from the transverse colon all the way down toward the rectum for defecation.
And who is driving this bus? What's the nerve supply?
It's a balance of power. The parasympathetic nervous system drives the movement. That's the rest and digest system. It's the accelerator.
And specifically, which nerves?
The vagus nerve covers the midgut, so everything up to that splenic flexure, and then the pelvic splanchnic nerves from the sacral spine S2, S4 cover the hindgut.
And the brake.
The sympathetic nervous system, it inhibits motility, clamps things down, part of the fight or flight response.
This leads to the cut wire effect the source mentioned.
Yes, if you damage the parasympathetic nerves during surgery, say you're doing a deep pelvic dissection for rectal cancer, you can lose the drive. You've cut the accelerator cable.
So the patient gets.
They end up with a lazy colon, a postoperative ileus, or severe chronic constipation.
There's also the microbiota. We hear about this everywhere now, but what does the source highlight as its actual physiological function in this context?
Right, aside from being a trendy topic, the bacteria are workers. Their main job is to ferment undigested carbohydrates to produce short-chain fatty acids.
Which are fuel.
Yes, specifically fuel for the colonocytes, the cells lining the colon. The colon lining literally eats the byproducts of the bacteria. It's a symbiotic relationship. They feed us, we house them. They also produce vitamin K and, of course, gas.
All right, we have reached the main event. Updated applied anatomy for cancer surgery. This is where we take everything we've learned and apply it to saving a life.
And this section is really about debunking myths.
First myth, margins are just centimeters.
Right. For a long time, the thinking was, if I cut 5 centimeters above and 5 centimeters below the tumor, I'm good.
But the source says that's wrong.
It's incomplete thinking. As we discussed, a margin is a vascular and lymphatic territory. You aren't cutting based on a ruler. You are cutting based on the blood supply tree we talked about. You have to remove the embryologic plane.
So if I have a cancer in the cecum, which is midgut, I'm not just cutting out the cecum.
No, you are performing a right hemiclectomy. You are taking the cecum, the ascending colon, and part of the transverse colon. Why? Because you need to take the ileocolic and right colic arteries at their origin.
And because you take those arteries...
You have to take all the bowel that they feed. Can't leave bowel behind if you've cut its blood supply. It would just die. It would rot.
So the extent of the surgery is dictated by the blood vessels, not the size of the tumor.
Exactly. You could have a tiny tumor the size of a pea, but you still lose half your colon because that's the vascular unit you have to take to get all the lymph nodes.
And the metric for success? How do you know you got enough?
The lymph node count, the pathological analysis, the standard of care, the benchmark, is that you must harvest at least 12 lymph nodes.
Why 12? That seems like a very specific number.
It's based on statistics and outcomes data. If you analyze fewer than 12 nodes, You run a statistically significant risk of understaging,
Meaning?
meaning you might tell a patient they are node negative, or stage 2, when they actually have a tiny positive node, stage 3, that you just missed because you didn't take enough tissue. And the treatment is completely different.
So 12 is the safety number.
It's the floor. A good oncologic resection often yields 20, 30, or even more, but 12 is the absolute minimum to say, with confidence, we looked hard enough.
Let's revisit the tale of two cancers one last time regarding the surgery itself. Right versus left.
Right hemicolectomy for right-sided lesions, left hemicolectomy or sigmoidectomy for left-sided ones. The principle's in the same, high ligation of vessels, but the anatomy makes the risks quite different.
How so?
In a right hemicolectomy, the connection, the anastomosis, is usually between the small intestine, the ileum, and the transverse colon. This is generally a well-vascularized area. The small bowel has a fantastic blood supply. Leaks are less common.
And the left.
In the left, you are often connecting the colon down to the rectum. This is deep in the pelvis. It's harder to get to. The tension on the connection can be higher. And the blood supply relies heavily on that marginal artery we talked about.
And you're working near the watershed zones.
You're operating in a more dangerous neighborhood, vascularly speaking.
Which brings us to the nightmare scenario, the leak.
The anastomotic leak. It is the single most feared complication in colorectal surgery.
The consultant pearl here was vital. Most leaks are vascular failures.
Unpack that. Surgeons, we often blame technique. Maybe the staples weren't tight enough. Maybe the suture slipped. But the data shows that. Usually it's because the two ends of bowel didn't have enough oxygen.
Ischemia.
Yes. Maybe the surgeon cut the mesentery too close to the bowel edge, damaging the marginal artery. Maybe there was tension pulling on the connection, stretching the vessels thin like a rubber band. Maybe they tried to connect right at that splenic flexure watershed zone, where blood flow is naturally poor.
So preventing a leak isn't just about sewing skills. It's about a deep respect for the anatomy.
Respect for the marginal artery. Respect for the watersheds. And ensuring a tension-free, well-perfused connection. That is the art of colon surgery. It's vascular engineering, really.
It's incredible how it all circles back. The embryology set the stage, the vascular anatomy drew the lines, the physiology set the conditions, and the surgery is just the execution of a plan that was essentially written before birth.
That is the perfect summary. Anatomy is the predictor of behavior. If you know the origin, you know the blood supply. If you know the blood supply, you know the lymphatics. If you know the lymphatics, you know the surgical margins. It is a logical chain.
And if you break that chain at any point,
you compromise the cure.
So what's the big takeaway for our listener? Maybe they aren't surgeons, maybe they are students, or just, curious people.
The takeaway is that the body isn't just a bag of parts, it's systems. This whole deep dive, it wasn't about memorizing Latin names, it was about understanding the why. Why do we get constipated? Why do surgeons worry about blood vessels when removing a tumor? When you understand the logic, the drying machine, the vascular tree, the embryologic rotation, medical decisions stop looking like magic and start looking like engineering.
I love that. It demystifies it.
And it highlights the insane precision required. We aren't just hacking through jungle. We are following a very specific ancient map.
Which leads me to my final thought for everyone to chew on. We've spent this whole hour talking about the standard anatomy, the textbook, the blueprint. But we also talked about anomalies. Malrotation, variation in blood supply.
Yes.
So reflect on this. A surgeon walks into the OR expecting the standard map, but every single human is slightly different. That arc of Riolan might be there, or it might not. The mesentery might be long, or it might be short. If anatomy determines outcomes, how does that individual variation change the game for every single patient?
That is the ultimate challenge. The textbook is the guide, but the patient is the territory, and the territory always wins.
The territory always wins. On that note, thank you for joining us on this deep dive. We'll see you next time.
Stay curious.